Abhilash to join us on the dais. Dr. KBB Abhilash is a professor of emergency medicine here in CMC and also the associate medical superintendent. He is the editor-in-chief of the Current Medical Issues Journal, and he initiated the first emergency medicine MD course in Tamil Nadu here in CMC. He has almost 200 publications in peer-reviewed journals, and his areas of interest include development of emergency medicine curricula and teaching and supervising residents and students, as well as clinical research in emergency medicine. Dr. Binila is also our first speaker for today. She is a professor and head of the Department of Critical Care in CMC. She is a fellow of the College of Intensive Care Medicine and also has extensive clinical and administrative experience in ICUs in India and in Australia. She is extensively published in international and national journals and contributes to critical care education as part of the basic and very basic courses here in CMC. Her areas of interest include advanced ventilation strategies and sepsis management. And today she'll be talking to us about HFNC, NIV, and ECMO.
Thank you so much for that introduction. So post-coffee, I expect people to be awake and attentive. And this is a very straightforward session, which I've titled Bridge Therapies in Critical Care, Road to Recovery or Path to Futility. And what I will be covering is high flow nasal cannulae, NIV, and VV ECMO. So three extreme spectrums of our topic of management of respiratory failure. And in order to facilitate this discussion, I'm using a case, which was a patient was recently admitted in the Ranipet ICU, which is a 30-year-old man with a 3-day history of fever, cough, and breathlessness while in the bone marrow transplant unit. And he was day 6 post-allogenic stem cell transplant for severe aplastic anemia. So on examination, he was actually tachypnic. He was on room air. His SATs were 86. He had a respiratory rate of 32. Heart rate was about 98, blood pressure 114/70. He had some bilateral diffuse scattered crackles, and his cardiovascular examination was normal. So I think for all of you sitting here, I mean, it's very clear that this gentleman has got acute respiratory failure, and they wanted to shift him from, BMTU to the ICU for monitoring because these patients can rapidly deteriorate. So when you look at a patient with acute respiratory failure, okay, there are several modes of therapies which have been available over the past 30 years. And I say 30 years back when, probably when I was a medical student, what was mainly available was the conventional oxygen therapy and invasive ventilation, okay? But over the past 2 decades, you've seen a rise of use of NIV, high flow nasal cannula, and VV ECMO in the management of acute respiratory failure. I don't know whether you can, and the main thing of this presentation is going to be how are we going to use these modes of therapy? Okay, when are you going to use it? When will you stop using it and consider escalating and to something else? This picture is a picture of a bridge called the Tacoma Bridge, which was built in the 1930s and was functionally put into action in July 1940. It was meant to be something which will last long in Washington. However, the engineers had misfired, and within 3 months of it being built, it collapsed. So just by November, the entire bridge had collapsed. And that's similar to what we face in ICUs, So how much we stress a body, okay? How much we stress a patient, how much we put the patient through a particular mode of therapy. If it's not the right mode of therapy, if you push the patient beyond a particular limit, it can actually push the patient into failure. So the options for this patient, keep coming back to the same patient post-allogenic stem cell transplant, these are the options that we have available. So the patient was on room air, okay, right? He was on room air and his saturations was 86%. Should we put him on conventional oxygen therapy, high flow nasal cannulae, non-invasive ventilation, invasive ventilation, or VV ECMO? Okay, so these are the options which are available for all of us. So if you look at conventional oxygen therapy, that is what we all have all across the wards. So you've got low flow variable performance devices, which are the nasal prongs, and the Hudson masks, which can deliver oxygen at 6 to 10 liters per minute. You've also got the high flow fixed performance devices, which means that you're delivering a fixed fraction of inspired oxygen, which are the venturi devices, and the non-rebreather mask. Okay. So I'm just going to tell you what are the problems which you can identify. If I use conventional oxygen therapy for this patient who's coming from the BMTU, can I anticipate any problems? Okay, so I just want to tell you, suppose I use a low flow variable performance device. He's only on room air and saturating 86%. Okay, this is just to give you an example. Suppose I put him on this example is from Dr. Georgian's book. If I put a patient on nasal prongs, the same patient on nasal prongs at 2 liters per minute. And this is just a picture to show if a person is tachypnic, okay, you can see here the respiratory rate going up from 5 to 10 to 20, okay. The amount of oxygen which is given from the device, because it works at 2 liters per minute, works out to 33 ml per second, it becomes lower and lower, okay, because the inspiratory time becomes shorter based on the, even with the same amount of oxygen which is being delivered through the nasal prongs, okay? And finally, the FiO2, which is delivered to the patient with a variable performance device, you can see for patient A is 0.41, patient B is 0.31, and for someone who's even more tachypnic at 20 per minute, it's 0.26, okay? So variable low performance, low flow performance devices tend to deliver lower amounts of oxygen as the patient's respiratory rate increases. So not a very good, even when he comes to ICU, this is not something which I would consider using for him. What about the high flow, which we talked about the venturi devices? Okay, so this is just to give you an example of what is our normal inspiratory flow. This is just an example, okay, considering we are breathing a tidal volume of 500 at a rate of 10 per minute. I've just kept it just to keep the maths easy. And the I ratio 1:2, you've got an inspiratory time of 2 seconds. The inspiratory flow rate, our inspiratory flow rate works out to 15 liters per minute. For a person with normal, it may work out to 12 to 15 liters per minute, all of us who are sitting here. Okay, now the high flow fixed performance devices, can I use this? Okay, so when I say fixed performance, it's delivering a fixed fraction of oxygen, which is different from the low flow, which varies depending upon the respiratory rate. So I've got the venturi devices and the non-rebreather mask. One thing to remember is, in these devices, if you've seen the flow meters in the ward, it goes up to a max of 15 liters, which matches a person's normal inspiratory flow rate. The guy who's coming to ICU, he's tachypnic. He's breathing at 32 breaths a minute, okay? So if I put a person on something like this, his inspiratory flow drive must be much higher at maybe 30 liters per minute. He needs more. If I give him just 15 liters, he may suffer and struggle with air hunger, what we call flow starvation, okay? So our patient, this picture has been taken with his permission, was put on a device which is known as high flow nasal cannulae, okay? So you can see that, which is sitting there in his nose. So this is just very proud to say that this HICA flow machine is made by one of our gastroenterology alumni. So it's a Make in India project made in Kerala, and it's much cheaper than the other high flow nasal cannulae, which is available for use, the OptiFlow and all that. And it works very fine, very well. So you can see here, it's got one place where you can adjust the settings in terms of the flow and the oxygen. You've got a humidifier, which can deliver humidified oxygen and heat it at a particular temperature. You've got a tubing, which is got a heated coil inside, and you've got the nasal cannulae, which are sitting here with an adjustable head strap. And here you can see the flow rate can go anywhere up to 70 liters per minute, okay, on this. And this is just a picture to show how you can go up from 30 liters per minute, 30% FiO2, all the way to 60 liters per minute, 100% FiO2 with the high flow nasal cannula. So you can actually give the patient an increased amount of flow with the high flow nasal cannula. Now, the advantages for the nasal high flow cannula are essentially fourfold, I would say. Okay, so the first one is, you can see here, as the flow increases from 20 to 40 to 60, okay, when you increase the flow to 40 to 60 liters per minute on the nasal high flow, you can increase the amount of, and you can increase the amount of fraction of inspired oxygen. The increased flow can generate higher airway pressures. Okay, so when you have higher airway pressures, that tends to increase the end expiratory lung volume. This increased recruitment, increased compliance. And generally they say that for every 10 liters of flow, you get a PEEP of around 0.8 centimeters, which becomes less if the patient's mouth is open. So through this, it can actually increase your oxygenation. It can also help in washing out the dead space because you've got increased flow, which is going out. It can wash out your anatomical dead space, and it can help in CO2 clearance. Both these mechanisms put together can decrease your respiratory drive, decrease your respiratory rate, decrease your work of breathing. And by decreasing your work of breathing, it further decreases diaphragmatic injury, okay? There's less negative pleural pressures, there's decreased transpulmonary pressures, and finally, there's decreased patient self-inflicted lung injury, which is a recent concept which has come up after COVID. Okay, so this can actually help in decreasing patient self-inflicted lung injury. It also provides air which is humidified and warm, and that can increase the comfort for the patient. Very interestingly, there was a young boy in ICU who was put on Hudson mask, and he told me, I don't want that. I want the other one. He said the air here is very cold. I don't know how many of you have actually put your hand against a mask. Go and put your hand against an oxygen mask, and the air which is coming is actually very cold air. And that can actually cause a lot of distress to patients who may be having some slight bronchospasm, can be very uncomfortable. And they're a lot more comfortable with the nasal high flow. So when do you actually use this nasal high flow? I think the first most important question is, you need to be safe, okay? As I said, don't stress the bridge. Is there a need for imminent intubation? And the reasons are many. Okay, I've just listed out a few, but the reasons are many. If there is a need for imminent intubation, do not even consider nasal high flow. You need to go ahead and intubate the patient. Now, what I've tried to do in this slide is just put together the evidence which is available for the different conditions which have been studied for nasal high flow. So these are the different conditions where there has been extensive research. So there's hypoxemic respiratory failure, post-extubation respiratory failure, post-op respiratory failure prevention, and peri-intubation. So these are the situations where high-flow nasal cannula has been studied in literature. Now, to cut a long story short, okay, as I said, I've given the evidence in a separate slides, and I've told Dr. Vignesh to share it with all of you. The evidence to date supports the use of high-flow nasal cannula in the first three conditions that I've highlighted as a conditional recommendation to decrease intubation rates in comparison to conventional oxygen therapy, okay? So it's a conditional recommendation of low to moderate certainty to decrease intubation rates in comparison to conventional oxygen therapy. There is no impact on mortality as of now, okay? If you look at hypoxemic respiratory failure, there's no benefit of high-flow nasal cannula over NIV in all the studies which have been done. In post-extubation respiratory failure, high-flow nasal cannula has a benefit in patients with a low risk of extubation failure. However, in patients who have a high risk of extubation failure, okay, maybe patients with some critical illness neuropathy, maybe older patients, maybe some patients with congestive cardiac failure, high risk of extubation failure, NIV performs better than high-flow nasal cannula post-extubation, okay? In post-op respiratory failure, the evidence is there's benefit in high-risk obese patients undergoing cardiac surgery, okay? Routine use in all other post-surgical procedures is now not recommended. Peri-intubation, there's no benefit of high-flow nasal cannulae over conventional oxygen therapy or NIV. So this is the evidence in summary. Our patient is immunocompromised, okay? He's post-stem cell, allogenic stem cell transplant. Is there a role for high-flow nasal therapy? This is the high randomized control trial published in 2018, 776 patients. This study showed no benefit of high-flow nasal cannulae over standard oxygen therapy in decreasing mortality or the need for invasive mechanical ventilation. A meta-analysis, however, which pulled together many studies, okay, found that there is a decrease in intubation rates in comparison to conventional oxygen therapy in immunocompromised patients. So you can consider using high-flow nasal therapy in immunocompromised patients over conventional oxygen therapy to decrease intubation rates. There's no impact on mortality. In hypercapnic respiratory failure, suppose you have, now there's a lot of evidence in stable COPD patients, patients who are on home oxygen therapy. This is a very expensive mode of home oxygen therapy, but high-flow nasal cannulae in comparison to conventional oxygen therapy has been shown to decrease CO2 and exacerbation rates and improves quality of life. In patients with mild to moderate hypercapnia, where the pH is 7.25 to 7.35, high-flow nasal cannula in comparison to NIV is non-inferior in terms of avoiding intubation and re-intubation after extubation. So how do you actually start high-flow nasal cannula? So if I have a patient, I would start with an FiO2 of 1, okay, and a flow rate of 60 liters per minute at 37 degrees. And I'd decrease the FiO2 to target a saturation of 92 to 94% and decrease the flow rate as the person's work of breathing comes down. How do I monitor a patient on high-flow nasal cannula? Okay, so you need to do clinical. I think a lot of focus has to be on clinical. What is the patient's work of breathing? What's their respiratory rate? Okay, is there any asynchrony, thoracoabdominal asynchrony? Anything like that which is available, you know that this patient is probably not doing well. The patients on high flow nasal cannula need to be closely monitored. This is the ROC score, which is SF ratio divided by the respiratory rate. May be difficult to see, but it is available on the internet. And a very, just to help you remember the ROC score, a ROC's more than 4.88. In my mind, I remember it as 5, okay, is good. It means the patient is not too bad on high flow nasal cannula. Whereas the lower ROCs at 1 hour, 2 hours, 6 hours, 12 hours suggests that the patient is not doing well. Okay, patient is very tachypnic and not really settling down with the high flow nasal cannula. How do you wean HFNC? There's no specific criteria, but as I said, once a patient's work or breathing comes down, you can come down on the flow rate and decrease the FiO2 based on the target saturation that you've put for the patient. The concerns, I think, are actually many, but they're just focused on the main concerns of high flow nasal cannula. One is delaying intubation and 2 is aerosolization. Now, delaying intubation, this is the first study which you can see here at the bottom, which actually showed that if you delay intubation on patients on non-invasive ventilation, the mortality is quite high. Okay, so when I say delay or late NIVs, when you're seeing more than 48 hours of use of NIV, has a high mortality, poor prognosis. With high flow nasal cannula also, they found that the patients who were intubated within 48 hours, suppose they were not doing well on HFNC, and they were intubated within 48 hours, as opposed to later, those patients performed much better. You can see that their outcomes, overall ICU outcome and their secondary outcomes are much better in the group that was intubated earlier. In immunocompromised patients, because we're still focusing on this is a big cohort study which has come up with the EPHRAIM prospective cohort study, which had about 1,600 patients, mostly malignancies, where 37%, a third of them were actually intubated first line. What we can see here, there's no difference in intubation rates if they were put on conventional oxygen therapy, if they put on high flow nasal cannula, NIV, or NIV plus high flow nasal cannula. But what is interesting and what stands out is that failed HFNC had the highest odds of mortality in comparison to failed NIV or the combination of failed NIV HFNC. So, in short, if the patient is not doing well, you want to switch early. You don't want to keep them on it for a long period of time. HFNC failure rate has been reported to be 26 to 38%. And our role in ICU is always to see, okay, fine, they're not doing well on HFNC. Can we do something to make them better? And these are the 3 things which have been looked at. So there's awake prone positioning, which was a very big thing which came out in COVID, and I'm sure a lot of you will be familiar with it. It increases oxygenation, but there's a challenge in post-op patients and obese patients. Flow rates more than 60 liters, okay, is something which can be done, but it can be quite distressing for the patient and they require a lot of sedation. Now, this is the new thing which has come up, which is the asymmetrical high flow nasal cannula interface. So what we have is actually symmetrical nasal prongs, but this device, it's an asymmetrical high flow nasal cannula interface. It's been shown to increase the peak airway pressures and can increase the washout of CO2 from the anatomical dead space. And I'll just show a picture just to help you understand that. So this is what a symmetrical high flow nasal cannula will look like, okay, equal amount of air going through both the nostrils, okay, whereas in asymmetrical, you'll have an increased peak airway pressures because of the increased flow through the larger sized opening and increased washout of carbon dioxide with this device. So this is on study. We don't have any hard evidence, but a lot of physiological studies which have been done, which have shown this benefit. The second concern was aerosolization. So a lot of concern in COVID. I know we did have a lot of patients on high flow nasal cannula, not just in our center, but several centers. And so the evidence to say that there's aerosolization with high flow or with NIV actually is very limited, and it's mixed evidence. So the patient failed HFNC, okay? Within, maybe a few hours of HFNC, he wasn't doing too well. He was still tachypnic. What are the next options? And I think the next option, all of you would agree, would be possibly giving a trial of non-invasive ventilation, okay? Over the years, non-invasive ventilation has gone up tremendously, okay? From 1997 to 2010, which you can see here, the extent of use of non-invasive ventilation has really gone up all across ICU and outside. I think even in the ED, it's being used quite widely. And the use of NIV has been shown to decrease over the past few years. There's an improvement in the outcomes. I think people are getting more comfortable in the settings of NIV and how to put it in terms of ICU outcome, overall ICU outcome, and irrespective of the diagnosis for which they've been put on NIV, the ICU mortality and duration of mechanical ventilation is much better with NIV use. This is the 2017 ERS ATS guidelines for NIV use for acute respiratory failure. And whatever I have put as certainty of evidence as 3+ or 4+ are conditions which have shown that there is a decrease in intubation rates and a decrease in mortality. So high flow nasal cannula, we showed, does not decrease mortality, has no impact on mortality, but it can decrease your intubation rates in some condition. So hypercapnia with COPD exacerbation and cardiogenic pulmonary edema are two conditions where the guidelines have said there's a strong recommendation for. In terms of immunocompromised patients, post-op patients, palliative care, trauma, and post-extubation, it's a conditional recommendation for, and there's no evidence of benefit in prevention of hypercapnia in COPD patients or post-extubation respiratory failure patients, prevention. So this is essentially what the guideline is. As I said, 3+ and 4+ is actually a mortality benefit and a decrease in intubation rates. In terms of ARDS, can you use NIV and HFNC? It's in the Japanese system of guidelines, they've actually put it as a grade B, which is conditional or weakly recommended. In all the other guidelines, it doesn't feature. So this is a 2023 article, which is showing where it stands. When you're monitoring the NIV patient, what do you do? Very similar to the HFNC, you are monitoring the patient clinically, okay? Like the ROX index, which I mentioned earlier. So ROX, what did I say? If a ROX is more than 5, okay, 5, it's a good sign. If it's less than 5, it's a bad sign. Likewise, there's the Chacko score, okay, for NIV use. And here also the number 5, you need to remember the number 5. But here, a score more than 5 is bad. Okay, so this includes the heart rate, acidosis, consciousness, oxygenation, and respiratory rate. Okay, and if a Chacko score is more than 5 at 1 hour of NIV, there's an 82% diagnostic accuracy of NIV failure. So NIV failure, I would say, you know, if you look at the evidence, it varies from 5 to 60%. Okay, 5% maybe for the COPDs and 60% for patients with ARDS. This is a study which showed that the NIV failure in this pooled meta-analysis was 48%. So about 50%, half of them fail NIV. And as mentioned earlier, if you push a patient longer on NIV, the prognosis is, mortality is higher with a poor prognosis. This is a study which we did here in CMC during the COVID times, where we actually managed a lot of patients on NIV, and we actually found a reasonable outcome, matching outcomes across the world. So, but the interesting thing is what we saw here. Okay, so just want to focus on this, the time to intubation. The people who failed NIV and survived were intubated a lot earlier. Okay, and you can see here that there's a cross here. So these were the patients who actually died, and this worked out to about day 3. So essentially it's saying the same message: don't strain the patient, don't push the patient too hard. If by day 2 or day 3 you're not seeing improvement, move on to invasive ventilation. So early NIV failure, one of the predictors of failure is an ABG done 1 hour after the NIV. PF ratio drop has been found to be an independent predictor of failure. Likewise, in this study, which is a much bigger study, the factors associated with intubation, patients on conventional oxygen therapy was a patient who was tachypnic at 1 hour post use of conventional oxygen therapy that was found to be associated with intubation. Patients on high flow nasal cannula, if their heart rate, they were tachycardic at 1 hour. So the first one is respiratory, the second one is heart rate. And in patients in NIV, if they were working very hard, so huge tidal volumes, okay, a drop in their PF ratio, that indicated that they could possibly fail and require intubation. So this is all at 1 hour following the therapy. So the patient failed NIV. So this patient failed HFNC, failed NIV, required emergency intubation within 24 hours, okay? And is there a role for NIV here in terms of intubation? I'm sure all of you would have seen this trial. It's a trial published in NEGM, which was called the Pre-Oxy Trial 2024. And this actually showed that the use of NIV for pre-oxygenation during emergency intubation, there was a decrease in hypoxemia during intubation. That was the primary outcome which was studied. And this is another interesting guideline, which is actually showing the role of NIV. So here they've actually, patients who required intubation with a PF ratio 200 to 300, they pre-oxygenated with nasal high flow. On the other hand, if the PF ratio was lower than 200, they actually pre-oxygenated with NIV, which is in keeping with the pre-oxy trial, which has just been published. Now, our patient did well, okay? We didn't reach VV ECMO, okay? But to complete the topic, I need to cover VV ECMO as well. So this patient actually got extubated, still in the ICU, but not on, I think on post-extubation is requiring some high flow nasal cannula, but is doing well. Now, VV ECMO, what's the role in acute respiratory failure? The use has gone up. Okay, maybe not in CMC. I keep calling CMC actually a high volume ARDS, low ECMO center, not a high volume, high ARD. We have a high number of ARDS patients which are actually managed without ECMO, and they do reasonably well, even though they fulfill the ECMO criteria. But overall, world over, the use of ECMO has increased, and ECMO essentially serves as another bridge to recovery, a bridge to transplant. Recently, we had done ECMO for a patient who was being recruited, being airlifted for a transplant in Hyderabad. So that is also another possibility. So there were two major landmark trials done 9 years apart, the CSER trial and the YOLA trial. And the CSER trial actually, he did show a benefit, but what I want to highlight, and the number needed to treat was only 7. What I want to highlight was the 95% confidence interval, which you see here, which is 0.05 to 0.97, extremely wide, okay? So very difficult to comment and say whether this study is actually reliable. And so hence they went on to do the YOLA study, which studied 331 patients, was stopped before reaching the sample size. And this was the criteria that they used. They used severe ARDS, defined as a PF ratio less than 50 for more than 3 hours, or a PF ratio less than 80 for 6 hours, or a PaCO2 more than 60 with a pH less than 7.25 for more than 6 hours. So essentially, there again, if you see, the focus is short periods of time because they're not stressing the patient for too long. In those patients, they recruited to the ECMO. There was a trend towards lower mortality in the ECMO arm, 35 versus 46%, 95% confidence interval crossing 1. And the meta-analysis also shows, which looked at both these trials, actually showed a mortality benefit, 90-day mortality benefit. So ELSO guidelines recommends VV ECMO for severe, acute, reversible respiratory failure that are refractory to optimal medical management, okay? So those are the things to remember. You have an acute respiratory failure, which is refractory to optimal medical management. So your medical management should have been top notch, okay? So good ventilatory management, treat the case properly, actually get the diagnosis. And the patient you should optimally manage the patient with proning, safe ventilatory strategies, both pressures and volumes, and you're still not able to ventilate or oxygenate. They use the same criteria as was used in the YOLA trial. So this was the criteria for use of VV ECMO, the same criteria which we mentioned earlier. And they've also mentioned that in addition to this, they mentioned that the patient should, the pH of less than 7.25 and PaCO2 more than 60 for more than 6 hours is it with a patient who's maximally ventilated. So the respiratory rate is more than 35 and the plateau pressures are less than 30 or 30 and less. So it's, you reached your peak and you can't proceed any further. That's when you try and escalate to ECMO. For immunocompromised patients, is there a role? It's a big challenging question, and we do face this question many a times in the Ranipet campus. Can we put a post-transplant patient on VV ECMO? It's very, very challenging, okay? So especially in the, when they have not engrafted, they have low platelet counts. A lot of our patients on ECMO need anticoagulation to maintain the circuit. So this guideline, which I don't have the time to go through, but it's available on the Lancet. It's an expert consensus statement, essentially says the same thing, okay? So for non-malignant hematological conditions, or for malignant conditions which have achieved remission, or maybe in the transplant patient, you can consider using VV ECMO, but patient needs to be safe to manage with the anticoagulation. So the platelet count should be reasonable. So many of them do not actually fulfill the criteria for VV ECMO. Hence, is something which is not offered, but there are actually case reports and case series showing benefit of VV ECMO in immunocompromised patients. So you need to know when not to give as well. So if a person is got an unreversible condition, not a condition candidate for lung transplant, severe brain damage, either a large stroke or a bleed, active hemorrhage, contraindications to anticoagulation, which is needed to maintain the circuit, severe immunosuppression, end-stage cancer with a life expectancy less than 1, severe endocrine, multi-organ dysfunction. And here again, the last one is what I would like to highlight. If a person is mechanically ventilated for more than 7 days with an FiO2 more than 0.9 and the plateau pressure more than 30, it's a relative contraindication. It means you've stressed the patient so much. So if you're considering any of these therapies, consider them early. There are a lot of scoring systems which can help you prognosticate when you're speaking to families to help predict outcomes and mortality when they are on VV ECMO. The preset score is a score with the highest area under the curve, more than 0.8. So putting everything together, so this is a nice algorithm which I found. Okay, so you've got the nasal high flow and non-invasive mechanical ventilation. Anybody on treatment, you need to monitor. As I said, clinical monitoring, you stand at the bedside and you monitor them. Look at the respiratory rate, look at the saturation, look for thoracoabdominal asynchrony, accessory muscle use. Those are all things which you need to look at your ABGs. There's worsening respiratory acidosis. In addition, we did talk about 2 scores. Okay, I talked about the ROX score. I said if a ROX is more than 5, it is good. Less than 5 is bad. Okay. Other one was HACOR for patients on NIV. More than 5 is bad. At 1 hour post NIV, it predicts failure. So if the ROX is low or the HACOR is high, you would consider escalation of therapy either to NIV for nasal high flow or to invasive ventilation directly. Okay. Delaying intubation. Remember that delaying intubation beyond 48 hours of the non-invasive therapy has been shown to have a poor outcome. So if you're making a decision, don't stretch the patient, push the patient. He's doing well on NIV. Let's keep him on, okay? You're probably going to aggravate self-inflicted lung injury. And if you intubate, also consider ECMO early in reversible refractory respiratory failure. So the take-home points, which I want to say, 30 years, you've seen HFNC and NIV come up as potential bridges to success in terms of decreasing intubation rates. But it can also be a pathway of failure. When I say pathway of failure, requiring intubation in some patients. So in high flow nasal cannula, we've seen the failure rate being up to 30%. NIV, the failure rate can vary from 5 to 60%. So the key is monitoring the patients and timely initiation of the next form of therapy. Okay, escalation to either intubation, deciding whether to put the patient on BB ECMO. So this is my last picture, which is just going to say, don't stress the bridge. Don't push the patient too hard, okay? Escalate early.